name is Rivka Hagen. Some of you have met me before in my travels. My background's in practice management, and I'm aware that there's probably more of a nursing focus in the room today, but essentially my practice management experience is some 20 years in primary care in rural Victoria. So I've looked after the Romsey and Lanesfield medical centres for a number of years, and then became the general manager of the Gisborne Medical Centre up until about 18 months ago. And since then, I've stepped aside from those day-to-day roles and now just really working in that training and consultancy space. So let's have a little bit of a look at this morning's agenda. So a bit of an overview really on what quality improvement is all about, and you've heard that word bandied around a fair bit, and you're going to be hearing a whole lot more about it. So we're going to really put a bit of a framework around that and give you a bit more of a deep dive into the theories and the ideas that underpin that quality improvement journey. So what it is, why it's important, especially in healthcare, that we are focused on quality improvement. There's also just a small link to the accreditation standards, because they reference quality improvement, especially now in the 5th edition as well. So just a quick recap on where that fits in. And then we're going to have a look at some of the QI strategies and some examples for bowel screening to kind of talk you through where you might be thinking and where your activities may be in that. We'll get you to do a little bit of activity work as the morning goes on as well. So what's quality improvement? And I guess before we delve into the more formal descriptors of what quality improvement is about, what does it mean to you when we talk about quality improvement? What are the ideas that you're thinking of? Maybe I'll just flip that back to the agenda. What does it mean to you? What do you think about when you think about quality improvement?
Improving what you're doing,
yep.
Reaching more people or getting people to do what you want them to do.
It's that notion of better. It is reviewing what you are doing and ensuring that you are focused on the outcomes of what you're seeking to achieve. What else? What other words might you use when you're describing a quality improvement activity?
Change.
Yeah, absolutely. It does have those tenets of continuous change, and working within practices, you'll know that change is absolutely constant, and we'll talk a little bit about that notion of change fatigue. When everyone is running really, really fast, that you get to the point where you say, no more. And that's kind of the barrier to stop things from improving over time. So yeah, absolutely change. Any other words that you might use, or any other ideas of what you think about when you think about quality improvement?
Opportunity.
Yeah. So recognising those times where doing things differently or adding things in or stopping doing things actually results in an improvement. So there's the official quality improvement descriptor there, the degree to which health services for individuals and populations increase the likelihood of the desired health outcomes and consistent with current professional knowledge. So it talks about all of those tenets that change for the sake of change is not enough. It needs to be based on knowledge, on scientific fact. You can't just go about and willy-nilly throw things around unless they are based on some data and on some learnings that have occurred prior to that. So the concept there is that quality improvement is systems-based. So health is a system of activities and policies and procedures and resources and skills that all work together to drive that change program. And they need to work together. It is not one person within a practice. And that is going to be one of the challenges for you as you embark on this particular project, but other projects as well, to really recognise that this is not one person's responsibility. It is actually a whole of organisation approach that you need to undertake. So one of the messages that I'm really keen for you to take back to your practices after today is, who is in my team? Who can help me to drive this? Who gets what we're trying to do here? And the more people within your practice that are on board with what you're trying to achieve, the higher the likelihood that you're going to see some success out of that. So secondly, the use of data to inform your service development. So how can you plan your services unless you've got a bit of a baseline measure from which to start? And it is a real question, because we know that many activities, especially in general practice, are still very ad hoc at the moment. So you've got a lot of reactive decision making without a lot of planning that sits behind it. And that's where a lot of the fatigue kind of comes in as well, because the structures don't necessarily support the activities that are undertaken. So looking at your data, and we're going to be talking about your Pencut data and the data coming out of your practice management systems, especially as it refers to the cancer screening project. The project that we're talking about here is a very specific improvement that we're wanting to put in place. So the good thing about that is that it makes it easy to define your ideas and your targets, because they're pretty well set out for you. But what we'd really like you to think about too is how that decision making and the definition of those ideas and goals and targets can inform all of your change management within the practice. So look at it as a broader concept than just the cancer screening. That's going to be really important. Then that notion of continuous improvement. We want to make sure that we are always on the lookout for improvement. And what that requires is really a mindset of being on the lookout for where those opportunities might be. And again, I'm talking far more broadly than just cancer screening here. So it's a mindset, it's an attitude of curiosity and desire to get better outcomes. And you want to be empowering the people that you work with to be recognising those opportunities as well. And we'll talk a lot more about that as well. We need to regularly review our changes to ensure that they are still meeting the objectives that we first set out to do. And therefore we need to evaluate on a constant basis. And this is again where looking at data cleansing and data analysis are really important to give you the yardsticks to tell you how you're tracking and how you're going. So there's a fair bit in that. Why is it important? Well, QI is obviously important for a whole raft of reasons. We have some really good stuff that happens within healthcare, and we know that. On a day-to-day basis, our patients need our services. We provide vital services to the community, and we do, on a global scale, we achieve some pretty great outcomes, and I think we shouldn't skirt over that. By and large, the work that is done is of high quality. However, we have high incidence of chronic disease. We don't have equity of access to services. The drivers of getting better outcomes, especially in the regional and rural areas, are not the same as what's being achieved in metropolitan areas. And very specifically too, and the more you delve into this, the more alarming it becomes, is that the rate of preventable errors is horrific within the healthcare sector. And that's globally too. So things not going quite right, or things going blatantly wrong, results in poor outcomes for patients. And so for those very reasons, we need to continue to ask what we can do individually and collectively as an organisation, as a PHN, and as a system of service provision. What can we do better? What do we need to change to turn some of those things around? And they are the tenets that really underpin quality improvement. So there's this thing called the quadruple aim, and you know, PHN people love this. And these are the motherhood statements that kind of describe what it is that we're wanting to achieve in this space of quality improvement. So we want improvements in population health. We want overall the population to be healthier, to thrive better, to live better lives. We definitely want to do that. We also want to enhance patients' experience of care. And if we just reflect on that for a moment, we know that the rate of complaints in healthcare is reasonably high. Often patients don't perceive that they get what they came for. They're not necessarily pleased with the services that they've received, and they would like to see better out of that. And the way that healthcare is delivered to patients, in sometimes an ad hoc fashion, not so much planned and proactive care, they are all barriers that stop people from getting better health outcomes. So definitely the enhancing the patient experience, it's highlighted here in green because it really ought to be probably number one. Reducing the per capita cost to the healthcare system. So healthcare is expensive. We know that. And by improving the way that we do things, we should well be able to reduce the cost of providing that. So we're looking at things like the reduction of duplication, avoiding unnecessary testing of patients. When you think about, you know, pathology testing that gets done at the GP practice and it gets repeated at the specialist practice, gets done again in the hospital system. Huge amounts of waste, and this is all falling back onto the taxpayers, of course, very, very costly. And the fourth idea of that quadruple aim is to improve the work life of healthcare providers, and that's you guys. So if we do all of this better, it not only achieves those other three goals, but it's going to make your experience in your working environment a whole lot better. If you're able to practice to the scope of your skill and your qualification and your experience, and that's done effectively, the right job by the right person at the right time, you're going to have far better professional satisfaction as well, and that's important. So this is the official quadruple aim descriptor there. Basically underpins the benefits that I have just spoken about, just given to you in the format that you've got in your QI toolkit. So all of this information you'll be able to reflect on in the toolkit that you've been given. I don't know whether you've had a chance to look through that prior to today, but there's some important information there. And the IHI is the Institute for Healthcare Improvement. They are the boffins that came up with this entire framework. It stemmed firstly from a triple aim, where the patient experience was actually not quite on there, and that's been developed further into that quadruple aim, which has really boosted that patient component there as well. So how does it work? Quality improvement is a systems thinking framework. The question you need to ask is, how can you consistently deliver the same quality of care across the board? So have a think about how you work within your practice. I'm sure, and certainly this has been my experience over the years, is that there are some good systems in place. Of course there are, you know, you've got appointment systems and you've got billing systems, and there is consistency in many areas of what you do, but there are also many pockets of ad hoc processes. And when we think about the clinical care framework, this is where a lot of that ad hoc behaviour comes in. Whether it is GPs deciding that their reminder and recall system is going to work a little bit different to everybody else's. There is not a system in place. There might be some, but it is not adhered to. Or there is just simply variation. How often do your results get checked? What are the processes in place? And of course, these systems are underpinned by a whole framework that needs to support those systems. So unless a system is defined, agreed upon, understood, so staff have been oriented and inducted to what those systems are, and the expectation and the culture is there that that is how we all behave collectively, those systems will fall down. And I'm sure that you can think of some situations within your own practice where you recognise sort of variation from systems or difficulty in defining what is your system. As an accreditation surveyor, I've come across this numerous times where when you speak to different staff members within a practice, you kind of get different answers on how a system is supposed to work. So the policy says one thing, the practice manager usually will follow that line fairly closely because they have devised that policy and it's been put on paper, but it hasn't necessarily been shared, it hasn't necessarily been understood, and it definitely hasn't been agreed to by the rest of the organisation, and that's where some of that fragmentation can come in. So avoiding those ad hoc services is going to be really key to ensuring that your systems are working consistently across the board. Secondly, SMART goals, and we're going to be doing a whole lot more about those. So SMART goals are ideas and goals that have these elements in them that make them easy to define. So they are specific. When you think about a goal, you need to be able to define that goal really, really well. If you have trouble defining what your goal is, you need to chunk it down and take it into smaller steps. Because if you can't clearly articulate your goal, it is too complex, it's too big, or it doesn't have the other elements of being measurable, realistic, or time defined. So we need to know the who, what, when, where, and why. And unless you can define that, your goal is just a dream, really. So in the pink lettering there, some is not a number and soon is not a time, kind of speaks to that notion that you can't be that loose to say at some stage we're going to be doing something, and it will be an improvement because we think it's going to be an improvement. It's all loose and ethereal, and you're not going to get the outcomes that you're looking for. So SMART goals are going to help you when we start talking about PDSAs, the plan, do, study, act cycle, to help underpin defining the activities that you're going to undertake. It's going to start with planning, and planning is SMART goals. Small, continuous and incremental changes. Big elephant. You can't eat the elephant in one go. You've got to take your quality improvement activities in small chunks. It helps to keep the team on board. It helps it to be understood. It helps it to be embedded so that you can share and demonstrate your improvements. And lots of little improvements over time lead to big improvement changes. So again, when your ideas are too broad to clearly define, you need to chunk it down, break it down into bite-sized pieces. And sometimes when this idea becomes better understood, you kind of go, oh, but I thought that was too simple an idea. That's not an idea, that's not a goal, that's almost nothing, but it isn't nothing. These are the bits that actually build towards creating sustained and big change. And I'm seeing some smiling over there. Have you got a comment or an anecdote to share, or can you relate or not relate?
We can relate, but when we talk about this kind of thing, we talk about PDSA cycles and the light bulb example, so it's become...
Have you got an example of a light bulb?
Well, there is the changing the light bulb, which is kind of the classic PDSA. And I think it's like the question is, how do you change a light bulb? And so...
It's a joke.
Yeah.
Check that the switch is working.
Uh-huh.
The plug is
The
plugged
plug's
in.
plugged in.
So then I guess my question for you is, are all the lights working at your practice at Springs Medical?
Oh, we try.
Work in progress.
Look, that's brilliant. That's brilliant. But yeah, look, it is about the simple chunking of your ideas, so don't overshoot it. The small, continuous, incremental change, easier to manage and achieve, and over time, the small changes become the big ones. How does it work? Number 4, measure your progress and keep score. How do you know that a change is an improvement? And define your success measures. So be specific. When we're thinking about the cancer screening work, we're talking about very specific numbers. We're talking about specific age groups, and you're going to be tasked with defining what your success is going to look like. And that's going to be different for different practices depending on where your journey starts. So you might say, we're wanting in the next month to have an extra 5 patients undertake the cancer screening test. And that may be your measure of success. For another practice, it may be 1 or 2, or it could be many more. It could be 15 or 20 or a percentage. How you define that is up to you, as long as it's realistic for your organisation. So defining your measures is really important. Still shamelessly, and that's definitely words that are used by the Improvement Foundation when they talk about quality improvement as well. Learn from each other. So I think this is why it's really important in terms of networking here too, that you guys stay in touch, share your successes. How are you going about your quality improvement activities? If you're going to be defining your PDSAs, your activity plans, and you're going to document those, try sharing those, and not just the bits that work, but also the bits that don't work, because we learn as much from our failures as what we do from our successes as well. This is a lovely, intimate little group, so I'm hoping that you'll all be wanting to share email addresses so that you can also flip questions and ideas across to each other as well as you're working over the 3 cancer screening programs. That will help you to still shamelessly. If it's worked really well for one organisation, guess what? You may not need to do all of the groundwork and the thinking behind it because it's already been done for you. And this is not just the case, of course, with cancer screening. A lot of work has been done, for example, in the space of diabetes management. The Improvement Foundation and the Primary Care Collaboratives have been working on chronic disease and especially diabetes care for many, many, many years. So they have thousands of PDSAs that they have collected over all of their tranches. And there's some brilliant nuggets in there. And you are not unique enough for your circumstance to have not been experienced before. So don't reinvent the wheel, use the information that's already out there. And a supportive culture is really important. So you'll hear from Kim and myself, and we get sort of pretty passionate about quality improvement and chronic disease management and how we can better work with our clients. And it's that passion and energy that you need to bring to these change management processes as well, and that's got to be done on an ongoing basis. So the way that you talk to your staff about this is going to be really impactful on their willingness to engage with this project as well. So if you're trying to get your team on board, you've got to sell that message really well to them as well. So the notion that everybody can learn, that we are not fixed in what we know and what we can do. We bring curiosity and a growth mindset to the work that we do across the board, not just in this particular project. There's those 3 words, the adapt, adopt, discard. So when you're thinking about your quality improvement cycles and your goals, once you have assessed those, your PDSA, you've come back to the assessment component of it, what is it telling you? Did it work? when you've tried out in small chunks what your improvement plan is, you've rolled it out. Did it work? Yay, great. Let's do some more of it. Let's broaden it out. Let's do it on a bigger scale now that we know we've got some good stuff happening. Were there challenges in the way? Do we need to tweak how we went about that? Because we found some problems in our plan and the way it rolled out that requires us to just rethink how we go about this. So we just adapt, we change it. Or do we discard it? That didn't work. For all sorts of reasons, our plan did not work, could not work, throw it out. We need to start with something else. Those are all three outcomes that may result. So what gets in the way? And we've kind of touched on this already as well. Team resistance. So if you don't have your people on board with you, day-to-day busyness. We're all incredibly busy in the everyday work that we already do. I get that. I have been there. I've done that. And I know that your days are already really filled. So my recommendation for that is ensure that, especially with this project that you have decided to undertake, you need protected time, and not just yourselves, but your team as well. So if you've got your practice manager on board and you have others who need to do specific activities in order to see the success, make sure that there is some dedicated time to allow that to happen, because otherwise it'll be sabotaged. You'll find that things simply don't get done. The lack of systems thinking. So if, again, ad hoc processes kind of fly around, then we don't get a good sense of what is our purpose and what is going to be the outcome that we're looking for. That notion of we've always done it this way, and that really speaks to that whole team resistance as well. So that fixed mindset of saying we've never undertaken this, I don't think it can be done, or I've always worked this way. And I suppose the thinking about, for example, your recall and reminder systems where, you know, one doctor decides to do something completely different. I've always done it that way. Breaking through those resistances is going to be key to getting those quality improvements. Complacency, we're okay, we're great. We're doing the very best we can. So those ideas that it's already as good as it can be is a total killer to the quality improvement mindset. Lack of curiosity, and that's a big one for me. I love that word curiosity. I think it really underpins a whole lot of opportunity if you wear the glasses of curiosity, of wanting to know, wanting to find out, how does it work? Why do we do this? What does it achieve for us? That curiosity will lead you down that pathway of quality improvement, and conversely, a lack of curiosity, that closed-mindedness, that fixed mindset is going to be the blocker in the way. So just a very quick flip through on how accreditation fits into quality improvement. So the really good news is all of the work that you're going to be doing in this project is what accreditation is asking for in terms of quality improvement. So the 5th edition standards for general practice in the quality improvement modules, so the standards are made up of 3 modules, a core module, a quality improvement module, and in the case of general practice, a general practice module. The second module is the QI module, and the first standard in that module speaks specifically about quality improvement, and these are the indicators that it stipulates. Our practice, so indicator A, our practice has at least one team member who has the primary responsibility for leading our quality improvement systems and processes. So it's about accountability. Who wears the hat? Who wears the responsibility for ensuring these programs gain traction? And that can be different people within different organisations. It could be your nursing team leader, or it could be a practice manager, it could be a GP. So it doesn't tell you who it needs to be, it just says someone needs to be held accountable. Indicator B, our practice team internally shares information about quality improvement and patient safety. So the sharing of information is kind of what I've been talking about all along, to say that you can't do this on your own. It's a whole of practice approach. So the accreditation standards ask you to define how you share that information. And again, the standards are not didactic in telling you how you need to do that. It could be via email if that works best within your practice. It could be via team meetings. It could be via one-on-one discussions. It's very flexible, but having one person doing quality improvement is not quality improvement. Indicator C, our practice seeks feedback from the team about our quality improvement systems and the performance of these systems. So it's seeking feedback. Don't just tell your team about it. They need to be on board. They're actually part of this conversation. So it's all totally consistent with what we've just gone through. And lastly, our practice team can describe areas of our practice that we have improved in the past 3 years. So again, it's saying that you can't have your quality improvement activity from 5 years ago as still being relevant today. So again, just anecdotally, what I used to hear a lot of when I would ask practices to define what quality improvement activities they've undertaken, a lot of it was infrastructure related. We've painted the walls, we've got new curtains, we've got our height adjustable bed, and yeah, I mean, it meets the accreditation standards, but this is wanting more from you now. So it is about that systems thinking and really embedding quality improvement into your everyday activities. So again, this program, document it, track it, that becomes your evidence for accreditation purposes. We've spoken about the fact that this is a team effort. Educate the team on the value of population-based screening. What do you think the value of population-based screening is? Can you define that? They need to know, why are we doing this? What's the value in this? Has anyone thought about that? Thank you. Yep. We're wanting better patient outcomes for this. Absolutely.
And targeting the right patients.
Exactly.
Patients at risk.
Exactly. So it might be a conversation about the difference between population-based screening and risk screening. So the difference being that the population-based screening looks at particular target groups that are at higher risk by their very nature versus screening a patient that has come in with already a particular symptom that you are then going to target. So it's the understanding of the team of why you're doing this that's really important. Unless they get that, it's really difficult to get that activity happening as well. So understanding the cancer screening guidelines, and our friends are going to be talking a whole lot more about this afternoon, about what those actual guidelines specify. So you're going to get a lot of information that you need to take back to your team and share it with them. Target populations for each screening program and some documented processes. So again, you need to look at all of those areas and get your team involved in order to get those outcomes happening. A little bit about the team dynamics and the ideas that come from your team. So remember too, that although you're going to be the leaders in this particular program, your team may have some really practical input into how that change management ought to take place, because these are the people that run your systems day in, day out in the practice. So before you start telling them what your program is going to look like, invite their commentary and their response too. So do we have a clinical and non-clinical leader? Who are the drivers of this particular project? What are the roles that have been assigned to each of those persons? And what are the time frames that we are looking at? You've got to describe those systems. What about skills? Does anyone need further retraining? Obviously today, as part of that skill building, to get all of that happening, but what about the rest of your team? What skills or additional skills might they require in order to effectively be team players in the change management process? And ensuring the protected time is available for each and every staff member. That's a tricky one, and that's probably one of the ones that I say, look at that very, very carefully, because you can have the best ideas in the world. If you do not provide space and time for those ideas to be put in place, the chances of success are really diminished. Okay, so we'll look a little bit more closely now at quality improvement and the bowel screening framework. This little page here, I found that in your guidelines in the big book that you've received. And as soon as I saw numerator, denominator and calculations and whatnot, I went, oh my God, I don't understand any of that. I need to sit down and interpret that. Looks like quite a complex little calculation there. So, this is essentially what it says. For the cancer screening, for the bowel cancer screening improvement cycle and improved rates of screening, you need to first of all establish your baseline data. So essentially that is what percentage of 50 to 74-year-olds have been screened in the last 2 years. So you are looking at your active patients. So these are patients that have visited at least 3 times in the last 2 years. And first of all, you want to know what is that cohort of patients that are between 50 and 74 years old. And then you can do your determination of which have had the fecal occult blood testing done or a colonoscopy within that 2-year framework. And that's going to give you that baseline data of what you have achieved and perhaps where your targets are going to be. So, in terms of calculating the percentage of eligible patients that have been screened, you basically take the total number of patients that have had some testing done and divide it by the total number of patients in that age group, and you multiply it by 100. So that's the percentage. Can I ask, has anyone done this calculation? Have you done any data extraction? Do you want to share with us, what that looked like and what your findings were?
I think for the bowel screening it was about 20%, was it? I can't remember. Have you got it there?
It's lower than for breast and...
So we just used the Pencut tool,
yep.
And then followed that filtering. And
yep. How hard was it to do? How easy was it to do?
It's easy.
It takes time being set aside and dedicated to doing it.
And I guess a confidence, building confidence in the data.
Yeah, looking at your data.
Actually getting to know the data and feeling confident that the numbers you're getting are truly reflective. I think it takes time, experience with using those systems for me, to feel satisfied that it's actually giving me correct data.
Absolutely. So what you're hinting at there too is that idea of clean data to make sure that all of your patients will hopefully have an age recorded, which will give you the age factors quite well. But the recording of the fecal occult blood test and the colonoscopy, how does that happen within your software, and how does that translate to your Pencut tool? So those are real questions that you need to have a look at before you can have total confidence that what the numbers are telling you speaks that truth. And so when we start to talk about quality improvement, we may not be able to go to this step immediately. We may need to question about how we're recording these things in the first place. And if it's not being recorded well so that it is extractable and interpretable, we need to find out how else can we get hold of that information. Are we able to get listings of Bowel Screen, the Bowel Screen people, to say who within our catchment has had screening, so that we can backfill and clean that data to ensure that we can do that. What are we going to do going forward? So part of your quality improvement activities might be that you need to provide some training to your clinicians and your nurses about how we record these particular tests if it isn't being done well within the practice to allow us to interpret that. So it's really taking that step back to where do we need to begin from in order to ensure that we can measure and track the success. And that's going to be quite individual. And I would imagine that for some of you at this stage, you'll say, I'm not exactly sure. But it gives you a framework for going forward and saying, well, that's what I need to find out first and foremost before we start doing the calculations. And then the second equation or calculation is, well, once we know who has been screened, we want to do something with the people that haven't been screened, because that's the ultimate target of what we're trying to achieve here. So if you take the total number of patients that you have in the age group that are active, and you take away those that have had the screening, then you are left with the patients who are under-screened or not screened. So in simple language, those are the major metrics that you're going to be working with. So in terms of the Pencut recipes, you've got a handout in your kit that talks you through how you do those extractions. So have a look at those, and when I did a little bit of Googling around and I went to the Pencut site to find out what they recommended, it kind of breaks it down even further into looking for men who are underscreened and also Indigenous patients who have been underscreened, and it gives you the full recipe, the step-by-step guide on how you go about achieving that. So the link is up there as well, but you've got the actual recipe in your kit there. If you've got top bar installed, so again, this is kind of going to the next step, you can create prompts directly out of that Pencut extraction that are going to interact with Pencut and give clinicians the visibility that you're talking about an underscreened or non-screened person, so that opportunistically when that patient comes in to see the GP, they'll see that flash up because you've set that prompt to show up, and then that conversation can be had about the importance of cancer screening. So again, it's highlighted in pink because it's quite a novel way that you can ensure that you keep engaging patients that are in that target group at the time that they're presenting. And it's just an alternative way, apart from sending SMS messages and reminder letters and the like, it's another opportunity for seeing some real improvements. So that's a really good one. And I was surprised at how many other recipes Pencut had available. When I had a look, I went, oh wow, it's like the cookbook of data extraction, and there is so much there. So if you get really enthused about looking at quality improvement in terms of clinical quality improvement, then this is absolutely your Bible, and I would really encourage you to have a look at all of them.
Rivka?
Yes?
Just a question. I understand where the active patient comes from, so
Yes.
3+ visits in 2 years. What about new patients that have signed on to the clinic? How do they get captured?
Well, again, I think that would be an excellent PDSA or a goal setting to ask that question. How do we target that within our practice? And I guess if you're asking for a direct answer, I would say, well, have a look at your new patient registration form and see whether it captures that information, or whether there is a pathway for those people who entered the data into your medical director or your ZMed or your best practice, that when patients of the right age group are data entered, that they are automatically prompted to look at that information as well. So again, I think there are going to be many novel ways to skin that cat, and it all depends on what works for the practice. But I would think that the original screening questionnaire would be the natural way to ask for that. Yeah. You got to think too, though, how old is my new patient? Do we want to ask every possible question about every possible quality improvement activity on a new patient information form that they may not be all that willing to complete at that time as well? So you've got to really think about, well, what's the purpose and where does it best fit in? And if you're going to be undertaking the cleansing and the data extraction regularly, and especially if it's going to be linked to TopBar, you may not need to do that and hassle your patient the first time they come to your practice, but they're going to be sucked into that vortex of regular review and then the updating of your TopBar. And so it naturally becomes part of the system anyhow. It's kind of easier. But I'm just kind of dreaming that up as we go along and saying, what might I do if that was the way it would work for my practice? And I'm certainly not saying that that's how it ought to be for everybody. Every practice works a little bit differently, and whatever works for you.
Sorry, Rebecca, just to also mention with the PHN, so the data that we're extracting behind the scenes in Pen is looking at all patients. So it is those who may have just visited once or twice in the last month. And how you do that is you just don't tick the active, and you look at the date range of visits within the 24 months. And the reason why we're doing that though is because we want to get that baseline to see if there's a trend. So if you're targeting your active patients, is that also having an effect on your new patients as well? So with the waiting room posters and just increasing that awareness.
Yeah.
So we're just having a look across the whole board. Is it having an effect?
Yeah.
Yeah.
Terrific.
I was going to add that you can select in their first visit within the last 6 months or whatever, try and capture those people as well, I think, when you're extracting the data.
Right.
Sorry, I'm standing very close. It's the mic. Okay, so just some planning activities for the increased screening. Talk to your staff. I think we've covered that really well. Think about your condition coding, and for today's purposes, definitely think about the colonoscopies and the FOBTs. Think about your reminder and recall system. How well is that used and understood, and is that systems based, and can you use that to better effect? Team roles and communications, obviously meet and discuss, get the whole team together. We've covered that really well. Think about your SMS reminder system. So does that have a role to play in engaging patients to undertake this screening? I guess I would have to say, I'd think very carefully about that. If patients who are in the target group are already sent a gentle introduction letter, they are then sent a kit, and they choose to ignore that, you would need to think very carefully about how you would phrase an SMS message to have effect where those systems haven't had effect previously. So just think about how you would go about that. Patients that are about to turn 50, so if you're doing your 45 to 49 health assessments, can you include in the health assessment the fact that they're going to have this invitation to participate in the system come up, and have a conversation about that to ensure that there is better engagement there. Reminder letters, so think about the templates. If you're going to send out letters to say, look, this is now from your doctor, I'd really like you to do that. The wording of that, the phrasing of that's going to be important. And again, I would flip back to the still shamelessly. I'm sure that some brilliant template letters have already been developed, so don't reinvent the wheel and use what's already available. Think about your marketing. Consider the barriers. So obviously fear, embarrassment and health literacy have a big role to play in the underscreened population. So think about the messaging and the tone that you use there to address those underlying barriers. Look at the clinical guidelines as stipulated by the NHMRC. They will give you some good guidance there as well. And of course the standards for general practice. Look also at follow-up systems. As far as the standards are concerned, the GP module indicated 2.2 relate to your follow-up systems. So if you are not exactly comfortable with how that's working at the moment, look at what's required of you. That will give you an excellent framework there. Think about your training and arrange any training that might be needed. And also think very carefully about how you're going to deal with positive results as an outcome of the increased screening and the likelihood that you're going to have to deal with more positive results. So you need to ensure that you're prepared for that as well, and you'll need to plan for that quite effectively as well. And your patient feedback mechanisms. How will you capture the patient's voice in these processes as well? Could it be a good idea to maybe do some focus groups or some targeted interviewing to say, look, we've sent out some of this material or we've knocked on your door. What made it work for those who responded? And perhaps also what made it not work for you, for those who didn't? Again, you need dedicated time to be able to do that, but very, very worthwhile overall to continue to define those systems. And finally, review your recall and reminder system. I'm actually going to flip past this because we're going to start running a little bit short on time. There is a handout there which is page 39 of the big checklist, and it looks at your reminder and recall systems, and it asks some questions of your preparedness in your ability to implement this effectively. So perhaps we might leave this, if there is a bit more time before lunch, we can come back to this, but I'm wanting to make sure that Kim's got sufficient time to cover her information as well. So if we don't get a chance to complete that today, then that could be a really good activity to undertake as one of the early checklists that you work on as well. Okay, so what I'd like you to do with the checklist is, you've got all of that in front of you, what I'd like you to do is just work your way through the questions and either tick them off or make some notes about where you are not clear about how your practice is managing those different components. So it's got a fair bit in there. Do we need to clean our data to establish an up-to-date list? So just have a think about what that means for your practice. Useful to have some conversations with the people that are sitting around you to ensure that you clearly understand what those questions are asking of you. And what I'm keen to do then, say in about 10 minutes, is just get some feedback from you about how you feel about that checklist. Where are the stumbling blocks for you at the moment, and where do you think your practice needs to put in some additional effort to be able to prepare for this quality improvement work? So have a little go at it. I'll float around and give you a hand if you're not clear, but about 10 minutes to work through that, and then I'd like to have a conversation about that. And how did you go with your checklists? How many items were there that you were able to say, yep, we're good with that, we're good to go? And more specifically, where has the conversation gone in terms of what you need to find out and what your next activities might be? So I'll start around the room, maybe just mention a few of the areas where you've identified some specific activities. Can I start in the corner here? Ashley? Yes, yep. So what are you comfortable with?
We've got new best practice, we've got new reminder systems so patients can opt out any time. So we make them aware that all the things I'll be signing up for when they get SMSs.
Yep, so that's nice and robust.
Yeah.
Great. And maybe some areas where you haven't ticked and you've defined the next step of what you need to find out or put in place?
So I think our data's being cleaned. I need to check that with them.
Right, so it could be or it might
Yeah.
not be. It's just finding out a bit more about it. Yeah, that's terrific.
I know that we have a reminder system, and I'm pretty sure people can opt out of that. But I know that we need to do data cleaning.
Okay.
That needs to be done. That's top of the list.
Yep, and that's often the case, and we were just having that conversation about that just before, that in order to kick off some of this good work, you've kind of got to go back and do the grunt work, which is not a lot of fun, but it is really crucial, but not just for this project, for other quality improvement activities in the space of chronic disease as well. So have you got some strategies around what that data cleansing might look like? What is going to be your first target for data cleansing?
Mainly like patients who haven't been there, like archived patients and patients that have doubled up because they've not come for ages, so they've signed up again but they're still in the
Yeah, exactly, and they're great activities to undertake. So searching for your duplicate patients through Pencut, that's actually really easy to do.
Yeah.
And then choosing which record is going to remain active, or merging them together to ensure that you've just got the one file, and getting that list of patients that aren't active. I know the definition of an active patient is having visited 3 or more times in the last 2 years, but in terms of making patients inactive, you might actually make that a little bit broader and say, well, 2 years, maybe that's a little bit too soon. Look at after 3 years, and then you can say, well, anyone who hasn't been here in 3 years, we're going to make inactive. And that doesn't have to be a manual process. So again, use your technology smartly in order to do those tasks, and then set up some recipes and some policies and procedures for doing that on a regular basis. Who's accountable? What's the process? What's the sequence? And how often are you going to do that? So yeah, great activity. What about the good folk at Springs?
Yeah, we were talking about. I missed what you said.
I think so.
Wasn't it?
We discussed with you, Rivka, that we need to go backwards before we go forwards. And before both Karina and I were there, some of these processes dropped off, and so now we're trying to rebuild that. So we're really needing to go back and get our data cleansed. And Karina's just proposed a policy and procedure around having data cleansing happen from the moment the patient either rings in or walks in the door to the time that they leave. And we have some unique things, probably like others here though, that we have tourists come to our area, so a lot that messes with our data. So some of what we've got are people that are one-offs, and so it's making sure that all those people are not in the mix, and we're not sending recall reminders. We do have a good recall reminder system. It needs revision again, and we'd like to go to SMS for that.
Yeah.
At the moment we're still doing letters, which
Yeah.
is inefficient.
Yeah, so that's that uniqueness that comes into different practices, and you will have different circumstances, and it's questioning how you can introduce that clean data right from day one. And when tourists are messing with your registers, how you can address that right from the outset. So
Yeah, we have casual. You can classify them as casual or regular, active in there. But it's making sure that is happening.
Yes, so
And
it speaks of staff training and orientation and induction, and ensuring that you have consistency, that you have a system to address that component. And there's a lot of work and effort that goes into all of that, but if you can get that right, and you get that the cleanliness of your database as a result of that, it's a great activity to undertake, but not a lot to show for, is it?
Yeah, but as we said to you, unless we do this, the data that we would base things on is inaccurate.
Yeah.
We don't have a true measure of improvement.
Yeah.
So that's very demotivating. That will be more demotivating than going backwards to go forward.
Yeah, absolutely. Yeah, and I think that's also why you want to ensure that you capture that activity as a PDSA, as a plan, do, study, act cycle, and document that. to have that demonstration that even the work that isn't visible to the outside, that it's a very internal process, has inherent value and is actually crucially important.
So even just making everyone in the place aware of like no free text, cleaning up problem lists, making sure the medication's in the right place, measurements are added right, just all of that really clear in a policy so that people know like how to record data. Yeah,
These are our minimum requirements.
Yeah, because I think there's still people who don't realise that.
Yeah, and I suppose another good strategy around that whole area of data quality and quality improvement is how can you keep that conversation going along the journey of the practice. So one of the common strategies might be to introduce that as a regular agenda item, just like you do with risk and quality and accreditation and OH&S. That data quality is an item and it can be spoken to at any time.
Oh, we're just laughing.
we just had that conversation before.
Oh, okay. I didn't hear that. Terrific. Okay, what about your ideas over here?
I guess I was going to catch up with the other nurses who have started the cleansing as well, and going through inactive patients and making the patients inactive that need to be inactive, and just sort of see where they're up to there. So I guess a bit more teamwork.
Okay, and which items were you able to check off, or just a couple of the items that you say, no, we're pretty good with that?
Yeah, so we follow up patients that don't attend. We've got a register manager as a practice manager. We don't really have a plan for when she's away, but we kind of loosely do. Yes, the whole team understands our recall and reminder system. We've got prompts in best practice that come up.
Yep.
And then also in individual appointments.
Yep.
Notes in those.
Yep. Terrific. Yeah, good stuff. Okay, so hopefully that's been a useful exercise, if for nothing else than to recognise that data cleansing is still an activity that's really high on the agenda for most practices, and that work really needs to be undertaken as the first step in allowing you to do that further interrogation and have confidence around the data that you're producing for the work, for example, with the cancer screening program. And I would imagine that'll take quite a few hours to get that sorted, but you're well on your way, so good stuff there. Any questions for myself or Kim on the content that's been covered so far, or any other comments that you would like to share?
Oh, that's okay, you can miss me.
Go, beg your pardon. I'm thinking it's the cancer screening ladies. They're all in this corner over here. Once I'm here, we're all done. Go, Meredith.
In terms of our data, we've got an amazing women's health nurse that pretty much has her hands all over data for cancer screening. So we've got Excel spreadsheets set up, and she does amazing follow-up with our patients. I think she had an amazing success story with a patient that she took 2 years to engage with. So
wow, that's
that was an
awesome.
Amazing outcome for her. We're supported by VACTO in terms of our data cleansing, so they do come out and do some data cleansing for us probably every 12 months, which is really helpful. I've got GPs that come to me and ask me to look at their data and tidy up their patients' recall systems. We've got recalls on our system from 2014 that just say pathology. So it's not linked to anything. It's not birds or thyroid function. So we're going through and tidying up all the data, dating back to 2013 and 14 at the moment. This one, the second last one, the health literacy for the reminder letters, I think that's one that I really need to look into.
Talking about health literacy, there's a fantastic online tool called Flesh Kincaid that allows you to scan any document for readability. So if Flesh Kincaid, I'll write this up for you. Kincaid, and it's called Readability. So that's a terrific resource to just scan any information that you make available to patients, just for language simplicity and readability, and it will come back and provide you with suggested alternatives. So really good tool. And in fact, I'd probably say you might want to scan most of your documents through there, because your staff are also part of the population, and if it's difficult to understand for patients, it could also be a communication barrier internally for your staff as well. So clarity of information is really key. Anything else? Pretty good? Okay, so any further questions before we break for lunch?